Okay, so looking at aortic aneurysms, we said that an aneurysm in general is a weakness in the wall of a vessel, and specifically here we're talking about the aorta. So if that is happening in the abdominal aorta, we call that a triple A, so an abdominal aortic aneurysm, but it could happen higher up inside of the aorta as well. Now, these are susceptible to rupture, and dissecting aneurysms occur when the inner layers of the aorta become separated. And again, the primary cause here is uncontrolled hypertension. That's what causes the vessels to weaken. That's what causes them to rupture. Now, we're going to look at some signs and symptoms here really quickly as far as talking about the aortic aneurysm pain versus traditional MI pain. But also very important to note that there is not a lot that we can do here in the field for a dissecting aortic aneurysm. And what they really need is a surgeon. So rapid transport is going to be really essential here. Now, talking about some differences between the pain. Generally, with an MI, the pain might be gradual and you have more symptoms. So again, like we said, maybe the jaw, maybe the shoulder, maybe nausea, maybe they're very sweaty. And so the pain is going to be gradual. With a dissecting aneurysm, it's going to be very abrupt without other additional symptoms, and it's going to be maximal from the onset, meaning it's going to start off really bad and it's not going to get any better. Now, the quality of the pain and the way that they describe the pain is really the key here. Generally, people with chest pain, especially if it's cardiac related, will describe that as a tightness or a pressure, maybe like an elephant sitting on their chest. But someone that's experiencing an aneurysm that's dissecting, they will describe this as ripping or tearing pain. So when you hear someone using those words, ripping and tearing, that should be a red flag for you. Again, like we said, with the region or the radiation, usually the aneurysm is going to be all the way through to the back, whereas the MI, they might have some back pain, but it's going to be more chest or jaw or shoulder type pain, not all the way through to the back like they'll describe this aneurysm pain. Now, looking at some clinical signs, the blood pressure discrepancy between arms might be a good indicator here, and also the difference in the femoral or carotid pulses. One is weaker than the other. Blood pressure is, more than 10 points higher or lower versus the other side. So those are some things that can help identify this as well. If this is an abdominal aortic aneurysm, you might be able to see that mass actually pulsating when you're palpating that area. So also something to look at if you do notice that, you don't want to touch it again. You want to make note of it and move away from it. Don't touch it again. We don't want to cause any additional pressure or potential for rupture. Now, some people who have these, they know that they have them and they're just not large enough to be operated on. And so it could have been something that they've been living with for months or maybe even years, and it's never caused them a problem. Just because they have an aneurysm doesn't necessarily mean that's what's causing their problem today, but we do want to make sure that we are looking for these signs of dissection. Now, looking at some patient assessment tips, of course, we want to make sure that the scene is safe for us. We're going to pay attention to our clues from dispatch, the scene, patient, family members, and bystanders, as far as the patient's medical history and what may be going on today. We want to get our general impression of the patient. If they're unresponsive, not breathing, and pulseless, of course, we want to go ahead and start CPR and call for an AED. We also want to take a look at their airway and breathing. We want to see if their oxygen saturation is less than 94 or 95%. We might consider applying oxygen. This says with a non-rebreather, but you want to use your good judgment. As we said, if the patient is complaining of difficulty breathing, then we want to address that individually. If it's severe, then a non-rebreather might be good. If it's minimal or mild, then maybe a nasal cannula. And if they're not having any difficulty breathing or shortness of breath at all, then oxygen may not even be needed. So other things that we might need to consider, if they're having inadequate breathing, then we might want to consider BVM ventilation, or if they're experiencing pulmonary edema, those rails. If they're conscious, we want to go with CPAP, and if they're unconscious, then a BVM if it's really severe, not just a mild. We hear this in the base of the lungs, but the lungs are truly full, and we hear that crackling or bubbling all the way up towards the top of the lungs, and the patient's work of breathing is really increased. We want to look at our pulse, rate, rhythm, quality, skin color, temperature, and condition, capillary refill, consider cardiogenic shock, and maybe what our treatment here would be as far as position, keeping the patient as warm as possible. We're going to be transporting our patient to an appropriate facility once we've stabilized them, and we want to transport in a stress-relieving manner, meaning we want to stay as calm as possible. We want to keep the patient as still and calm as possible, reassure them that you're doing everything that you can for them, and really, again, like I said, just trying to keep them as pain-free as we can. Looking at history taking, we want to get our sample history, but we're also going to ask specific questions about the chest pain if that's the chief complaint. And here is a prime time to use that OPQRST. So again, remembering that that stands for onset, provocation, quality, radiation, severity, and timing. So what were you doing when this started? Does anything make it worse or better? Can you describe the pain to me? Does it radiate anywhere? Can you tell me a number on a scale of 1 to 10 that you can rate your pain? And then how long has this been going on, or has it ever happened before? So this is a prime time to use that OPQRST mnemonic. During our secondary assessment, we're going to focus on cardiac and respiratory systems, looking specifically again at circulation and respirations, measuring our vital signs and reassessing every 5 or 15 minutes depending on how stable the patient is. And again, we want to make sure we're looking and staying alert to the possibility of cardiac arrest. That's always a risk, especially if we've got a cardiac problem. If you feel like the patient is drastically declining, going ahead and applying the AED pads but not turning it on would be appropriate. We want to reassess any interventions that we have done. We want to call for ALS if we need them. If we have the ability to get a 12-lead EKG, we want to have already gone ahead and done this during our initial assessment of the patient, and whether we're transmitting that to a paramedic provider, whether we're transmitting that to a hospital, whatever we need to do. And then we also want to make sure we have enough information to give adequate report regarding communication and documentation so that we can give an adequate call in there to the hospital. Now, looking at some treatment for chest pain and discomfort. Again, is this going to be a positional thing? So is the patient more comfortable sitting up or laying down? Usually laying down is not going to be more comfortable for people with chest pain. They're usually going to prefer to sit up, maybe even in a tripod position. So accommodate that if you can. We want to give oxygen if it's needed or indicated. We're going to prepare to give our aspirin and our nitroglycerin as well. So remember, with aspirin, we're going to give 4 81 milligram tablets of chewable baby aspirin, which is 324 milligrams total. And we're going to have the patient chew those aspirin and then swallow them. And we're giving this because of the platelet aggregation inhibitor effects that we're going to see here. So remember, this isn't a blood thinner, but what it's doing is causing your blood particles and platelets to become less sticky, essentially. It's not going to bust up a clot that's there per se, but it is going to help prevent the clot from getting bigger or new ones from forming. And that's our goal and our hope here. So even though aspirin can be given for mild pain like a headache or for fever in other instances, remember, we're only giving aspirin for chest pain, and it's not for the pain. It is as a platelet aggregation inhibitor. Looking at nitroglycerin, we have 2 forms available most of the time, tablet and spray. Both of those doses are 0.4 milligrams. And we want to try to look and see what's going on here. Is the patient a candidate for receiving this? So remember, in the state of North Carolina, they say that the patient needs to be prescribed nitroglycerin for us to give it, or we need to call medical control. So that doesn't mean that we can't give it if they don't have a prescription. It just means we need to pick up the phone or radio and make that ask that question from our medical control personnel. Now, what is this going to do? It's going to dilate our blood vessels, specifically the coronary arteries, and help to increase blood flow past the point of the blockage. So whether it's a blood clot that's there, whether it's plaque, whether it's the inability of the vessel to dilate on its own because of loss of elasticity, our hope is that we are going to give this nitroglycerin, and it is going to open those blood vessels and get blood past the point of occlusion to stop what's happening here, stop the death of the tissue. That's the goal. So contraindications, reasons that we would not give this nitroglycerin would be if the systolic blood pressure is less than 100, because remember, with that vasodilation is going to come some hypotension potentially as well. So we want to be cautious there and make sure that the patient has a systolic blood pressure of 100 or higher. We also don't want to administer this to a patient who has already taken erectile dysfunction medication in the last 24 to 48 hours, depending on which medication and how long it stays in their system. Because it's also a vasodilator, so vasodilator on top of vasodilator is a bad day. So we want to avoid that. We also want to avoid this if the patient has a head injury or if we suspect that this is that aortic aneurysm. If you suspect because of how the patient describes the pain or because of their history that that's what's going on here, then we want to avoid the nitroglycerin because that's only going to cause that to become worse and essentially lead to the patient's death. So we want to avoid that if that's how the patient describes their pain or we for any reason suspect that this is an aneurysm that's rupturing. Again, when we're administering any medication, but specifically looking at nitroglycerin here, we want to make sure that the medication is not expired or contaminated. Again, if the medication is not prescribed for the patient, that we're contacting medical control and that we're keeping ourselves safe and protecting ourselves by wearing proper PPE, including gloves. We want to make sure if this is a spray that we prime the pump by spraying one spray into the trash can before we administer into the patient underneath their tongue, but always into the trash can, not just into the air around us, because that could put us in danger. Looking at cardiac monitoring, if we have the ability to get that ECG for it to be reliable and useful, they've got to be placed in the correct spot. And so we're going to look at some basic principles here to help minimize the artifact, which is the interruption of the interpretation there, just some bunch of squiggly lines that don't mean anything, don't make any sense, that just interfere. And so that's what artifact is. So we may need to shave any body hair if it's really excessive. Usually you'll carry some portable razors that will allow you to do this. You might need to rub the electrode site with alcohol swabs before application if the patient is having trouble with it sticking, making good contact. And we want to attach the electrode to the ECG cables before placement, meaning we're going to snap those on rather than putting the leads onto, the electrodes onto the patient and then snapping the cables on or the leads on. We want to make sure that those are touching each other first before we put them onto the patient. And then we want to confirm that we've got good electrode placement on there so that they're making good contact and that they can read appropriately, which we're going to look at here in just a second on the next couple of pictures, looking at both the 4 and the 12 lead placement. And I've also given you another resource, another video that is going to show you how to place those 12 leads specifically. And one of the videos also has another example of 4 lead 2 so that you can see how those are placed appropriately. Now here on the left side, that's the 4 lead ECG, and so these are always placed on the limbs. Up here in this picture, they're showing that the lower limbs, the green and the red, are actually placed on the abdomen, but you're going to get a much more effective reading, especially if this is a larger or more obese patient, if those are actually placed onto the legs. So onto the thighs or around the calves or ankles is going to give you a much better and clearer reading. Same thing with the top leads, the white and the black. Those are going to give you better readings if you actually place them on the arms, up at the shoulders, or around the wrists, and not on the upper chest, because we don't want those to interfere with our V leads for the 12 lead. Okay, and so these are going to be labeled most of the time with LA, like left arm, or RA, right arm, RL, right leg, LL, left leg. But just for us to keep it simple for you to remember how those 4 leads are placed, you want to remember that you've got white on the right and then smoke over fire. All right, so white is always on the right, and then on the left-hand side, you've got smoke over fire. That's black over red. And if you need to know where the green goes, that's process of elimination, but you can also say clouds over grass, if that makes more sense to you. So white on the right and smoke over fire will really help you keep those together. Now this on the right-hand side is going to show you how the 12 leads should be placed, but I encourage you to watch the additional videos that I posted for you guys so that you can actually see on a physical human how these are placed. Placement of the 12 lead is an EMT skill. So interpretation of the 12 lead is a paramedic skill. You need to be a paramedic to interpret what that means. But the placement is an EMT skill, and certainly something that you'll be doing quite often, both in a clinical and a work setting whenever you have the opportunity to do so. So please watch those videos and let me know if you have any questions about that. So I'm going to stop this video here, and we will pick up in part 4.